As you may be well aware, we've had these series since last year when the pandemic started. We took a break towards the end of the year. We restarted again beginning of January when the pandemic hit the second wave. Things seem to be settling down now, and we feel right now is a perfect opportunity to continue our medical education and share our experiences while the second wave has settled. It's inevitable that we will get a third wave, I think, given that our vaccine drive is very slow. So in the interim, it's important that we keep learning. Again, this week, we're going to have Dr. Patel, whom I'll introduce in a few slides, and I'll also introduce the topic for today. Next slide. As usual, we have to go over our house rules. It's very important to really respect these. Please mute your mic when the speaker is talking. It's very important for other participants to be able to appreciate what she's saying. This webinar series is co-organized by Ministry of Health, Botswana-Rutgers Partnership, Botswana-Harvard Partnership, as well as University of Botswana. You can join the mailing list by emailing Vusindaba, which is at the email vn, vindaba@globalhealth.rutgers.edu. These sessions are over Zoom, and they have been since last year. And again, please do mute your microphone during the presentation. Questions are allowed, as well as discussions and suggestions. You can use the chat functions. There are moderators as well as faculty that will monitor these questions. Some will answer them immediately on the chat function. Others will be answered or discussed at the end during the Q&A. These sessions are recorded. They are made available on YouTube under Botswana-Rutgers COVID-19 series. And we do appreciate feedback. Please do tell us on how we can improve these presentations. Also, give us suggestions on topics that you'd like to discuss as well. We would really like that. Next slide, please. So this is where you can actually access the recorded videos. Last week's talk was on hypoxia and hypercapnia. It was really great because it concentrated really on physiology. So I believe that webinar is actually available online. Please, if you haven't seen it, I would highly recommend that you do go on YouTube and actually look for that link and go through that teaching. So there's all the webinar series actually available from lecture 1 since last year in April, and all the way up to now. So all the webinar series that we've had or hosted with Botswana-Rutgers Partnership are available. Please go through these. Some of them, of course, are general, but most, the good thing about them is that they have, they are specific to Botswana, and we discuss things that affect us during this pandemic. Next slide. A very, very important website. I cannot stress enough, covid19portal.gov.bw. Please visit this website, maneuver around it. It will keep reminding you in cases where you need to advise a health official, a khosi in the peripheries, a businessman, or even patients or colleagues. If you go to this website, you see these 6 about options opening up, but the most interesting one is probably the document library. When you click on that, next slide. So when you click on the document library, this is what appears. The document library is a house to all our guidelines in terms of clinical, how to open up a business, pregnancy guidelines, pediatric guidelines, the overall isolation summary, as well as managing people in the workplace that have symptoms. So this guides the country as a whole from both a clinical and a public health perspective. So these are actually quite good, and it makes your life quite easy. Next slide. On to today's talk. Today's topic is pulmonary embolism. We know that COVID-19 is an angiogenic and thrombotic virus. It seems to have those properties. We've seen lots of case series. We've seen papers published that talk about pulmonary embolus as a complication of COVID-19. And we've seen it here with our cohort of patients at Seki, Dumile, Masira, including even up north in the regions of Francistown. So we thought today we should talk about pulmonary embolus and pulmonary embolism, but concentrating really on risk stratification and management to update ourselves on what the guidelines are saying. I think Dr. Patel is not going to concentrate really on venous thromboembolism or deep venous thrombosis, but rather we will try to talk about and vision into pulmonary embolus and see how we can maneuver and manage our patients while the pandemic continues. Dr. Patel is a pulmonologist with Duke University. She's currently under the Division of Pulmonary Allergy and Critical Care. She graduated from University of California in San Francisco and went and did her internal medicine and eventually doing her fellowship and rejoining Duke University as faculty. She's at the moment an associate professor. She gave us a talk last week. She's back again this week. We're privileged to have you. Welcome, Dr. Patel.
Great, thank you very much, Dr. Palai. So just to reiterate what Dr. Palai was saying, and because I'm sharing my screen, I am unable to see the chat function. So if any issues come up, just Palai or Dr. Gaolathe just interrupt. But yes, so as Dr. Palai mentioned, PE is a very broad topic. And so, you could easily cover 2 or 3 hours talking about diagnosis and then different management options. So I chose to focus on risk stratification and management of acute PE with a particular emphasis on indications for lytic therapy, because these were questions that have come up multiple times during my time here at SKMTH. And then we'll also, of course, talk about management considerations in the COVID-19 era. So starting off with basic definition. So PE is a pulmonary embolus. It's any embolic occlusion in your pulmonary arterial system. Most commonly, it is due to a thrombus. And, we're not really going to cover diagnosis, but just as a general rule, any patient who presents with dyspnea, chest pain, or sustained hypotension without an alternative obvious cause, PE should always be on your differential. And this is just an axial view of a CT PE scan, and you can see a large saddle embolus traversing the trunk of the pulmonary artery. So in the pre-COVID era, it's estimated that there were 10 million cases of VTE per year worldwide. So venous thromboembolism includes both deep vein thrombosis, most commonly in your lower extremities, as well as pulmonary embolism. The true number of PE cases within that was likely undercounted. In the COVID-19 era, it's very likely that the number of thromboembolic events has increased because COVID-19 is associated with increased thromboembolic complications. Many of us have seen this firsthand in our clinical practice, and it's also supported by the literature. So studies from Europe report an incidence of PE in COVID-19 patients of 23 to 24%. And that compares to maybe around 5% in community-acquired pneumonia. So it's significantly higher. And then of note, a study of patients with COVID-19 pneumonia in Paris noted that they found 32 PEs in 137 patients that were admitted with COVID-19 pneumonia. And 17 of those 32 PEs were found after admission in patients who were already on prophylactic anticoagulation. So it's something that's another sort of unique thing about COVID is that it seems to, we seem to see more PE despite use of standard DVT prophylaxis. And then, just to another study sort of highlighting the difference between COVID-19 pneumonia and other pneumonia. There was a retrospective case control study of 144 patients from the United Kingdom, and found that the adjusted odds ratio for pulmonary embolism in hospitalized patients with COVID-19 pneumonia was 3.2 when you compared it to patients who were hospitalized with community-acquired pneumonia in the pre-COVID era. Of note, in this case control study, the authors didn't find any differences in need for critical care or mortality between the two groups. But when they looked just at the patients with COVID-19 pneumonia, they found that the presence of PE was associated with a higher likelihood of needing ICU level care. And so we see that the burden of disease is pretty significant in the COVID-19 era. So now we can move to definitions. So massive PE is defined as a PE associated with hemodynamic instability, and hemodynamic instability exists on a spectrum. So you can have, systolic blood pressure of less than 90 millimeters of mercury for 15 minutes, and that can qualify as hemodynamic instability. And then your spectrum can progress to refractory hypotension and shock, and then ultimately to cardiac arrest. When I was in training, I was also taught that patients presenting with syncope should be considered to have massive PE. And so I had initially listed it on this slide, but when I went through this week to review the literature, it seems like it's a little bit more complicated. So we will get to risk stratification models shortly, but most of the risk stratification models that exist for PE do not take syncope into account. And there was a systematic review and meta-analysis on the prognostic impact of syncope and PE that was published a few years ago in 2018. And the authors found that the odds of hemodynamic instability, RV dysfunction, and death were higher in patients who presented with syncope and PE. And this was a pretty robust systematic review. It contained 29 studies and almost 22,000 patients. But when the authors restricted the analysis just to hemodynamically stable patients, they saw that the association between syncope and adverse outcomes was drastically attenuated. And so they concluded that it may be the hemodynamic instability that presents with syncope that can drive the association with worse outcomes. And so that was good for me to know. So I think the question of what you do with syncope and PE and whether you classify it as massive or not, it's a little bit gray. And so we talked about massive, now we talk about submassive PE, which is the other sort of main category of patients that we'll focus on in this talk today. So submassive PE is kind of an older term for what is now known as intermediate high-risk PE. And that is the presence of abnormal RV function and myocardial injury in the setting of a pulmonary embolism. So abnormal RV function is determined based on CT imaging findings and echo findings, which we'll go over shortly. Myocardial injury is determined by the presence of an elevated troponin plus minus an elevated brain natriuretic peptide. And so to go into how we define abnormal RV function, so if we look at CT, there are multiple indicators that suggest RV dysfunction on a CT scan. So the most common one that we see is an increased RV to LV diameter ratio, which you can see in these top two images here. You can also see leftward bowing of the intraventricular septum here. And then you can see reflux of contrast into the inferior vena cava and the hepatic veins. So there was a systematic review published in 2015 of 49 studies and over 13,000 patients that looked at CT parameters and prognosis in acute PE. And of the different findings that you can see on a CT scan, they saw that an increased RV to LV ratio was associated with a 2.5-fold risk for all-cause mortality. And so of all the findings, this is the one that I would pay the closest attention to. And, in the US, I'm spoiled by having a chest radiologist who I can just call, but that's not always something that you can rely on. So it's important to know how to measure this yourself. And so a rough rule, there's different ways that you can determine the ratio. One method I saw reported in the literature is that you find a mid-ventricular cut of the heart, and then you measure at the widest width of your RV and your LV. And it's important to measure the subendocardial width. You do not include the wall. And you're looking for a ratio of 1 or greater. And then we look at echocardiogram. So I'm not a cardiologist, but when I look at this, I think, okay, this is pretty normal. This is an apical 4-chamber view. So you have your LV here, you have, or your left ventricle here, you've got your left atrium here, your right atrium here, and your right ventricle here. And so you see that your LV is bigger than your RV. Everything seems to be squeezing pretty robustly. This looks pretty good. Unfortunately, this next one doesn't look quite as good. So you're in the same, the axis is slightly tilted, but you're still looking at your left ventricle here, your right ventricle here, your right atrium here, and then your left atrium here. And so already you see that the RV looks markedly big and definitely bigger than your LV. It looks like the septum is bowing a little bit into the left ventricle, and then you see that your RA is quite dilated. So if I saw this echo, I would be worried about RV dysfunction. And then I would be extremely worried if I saw this echo, which let's say occurred in a 70-year-old gentleman who is healthy and active and recently took a long car trip. So again, you're in an apical 4-chamber view. You have your LV, your RV, your right atrium, your left atrium, and then you see this giant thing flopping in and out of the right ventricle. This is a clot in transit. If you ever see this, be very nervous because it's associated with extremely high rates of morbidity and mortality. So if in patients who are treated with anticoagulation alone, who have clot in transit, your mortality still approaches 40%. And so in cases like this, ideally you would treat with thrombectomy. So once you diagnose your patient with a PE and you classify them as massive, submassive, or sort of low, intermediate risk, you want to risk stratify them, as this will help you identify patients at risk of an adverse outcome during hospitalization. And if you identify a patient as being at high risk or low risk for an adverse outcome, that's going to affect your management. It's going to affect whether or not you admit them to the hospital, and it's going to affect how you, what medication you use to treat their PE. So there's multiple models available to aid in the risk stratification process. I'll only focus on a few here, but just be aware that there are many more. And so the first that I'll talk about is the Pulmonary Embolism Severity Index, or PESI. So the PESI score, it's a prognostic model that incorporates 11 patient characteristics that were independently associated with mortality in a cohort of over 15,000 patients in the US presented with PE. And then they took their scoring system and validated it in an external sample of patients from Europe. So for each characteristic, based on the magnitude of the association with mortality, they assigned a specific number of points to that characteristic. And so there's, as I mentioned, 11 in total. So you see that there's 2 that are kind of demographic, your age and your sex. Then you look at chronic medical conditions, and then you have 6 parameters that are based on your physical exam on presentation. And so based on the points assigned with these characteristics, you are classified into one of 5 severity classes. So the classes range from a very low level of risk to a very high level of risk. And they found that if they looked at their internal and external validation cohorts, if you fell into the risk class 1, which was very low risk, you had a less than 2% mortality at 30 days. And then you contrast that with people who fell into the highest risk category, who had a mortality of anywhere from 10 to 24.5% at 30 days. So the nice thing about the PESI score is that you can calculate it on your initial assessment. You don't have to wait for blood work. You don't have to wait for imaging. But the downside is if you're working in a busy A&E, it's you have to think about, oh, what are these 11 factors, and oh, how many points go to each one, and it can get a little bit difficult to calculate it if depending on your clinical setting. So because of this, a group of American and European researchers developed a simplified PESI rule for estimating 30-day mortality in PE patients. So they did this using a registry of about 1,000 patients with PE in Spain. And so in this group of patients, they found that 6 variables in particular were especially useful prognostically. And instead of giving each variable its own unique point value, in the simplified PESI score, if you have a predictor, you get 1 point. And so, instead of having to calculate age in years, it's, are you over 80? If you are, then you get a point. Do you have cancer or any chronic cardiopulmonary disease? If so, you get points. And then looking at vital signs, focusing on pulse, blood pressure, and pulse oximetry. So it's a lot easier there's only 6 things to keep track of, and you don't have to remember unique points. And then you're either low risk or you're high risk. So if you have a score of 0, then you're considered to be low risk, and your 30-day mortality is around 1%. If your score is 1 or more, then you're considered to be high risk, and your 30-day mortality is 8.9 to 10%. And so this scoring system can be particularly helpful when you see someone with PE in the A&E and you are debating, is this an appropriate patient who can do anticoagulation in the outpatient setting, for example. So if they have an SPESI score of 0, then you may be more comfortable sending them home. And it performs pretty well compared to the original score. So despite having fewer variables, the test characteristics of the simplified PESI rule were comparable to the PESI, as was the accuracy, which we can see in this figure that showed the receiver operating characteristic curve for both scores. So the PESI and SPESI scores were developed primarily to predict 30-day mortality, but that's not necessarily the only adverse outcome we care about in patients with PE. We also are interested in being able to predict who is going to develop hemodynamic collapse, who is going to develop recurrent PE. And we care about that particularly in hemodynamically stable patients, because if somebody shows up with massive PE, you already know just from their hemodynamics that they're at high risk for adverse events. But it's the patients who show up with normal blood pressure, and maybe they've got some indicators of right heart strain or right heart injury. Those are the patients where it can be a little bit harder to predict who's going to do well and who's not going to do as well. And so to try and get at this, there was a group of researchers that looked at 848 normotensive patients who had PE, and they found that 4 factors were independently associated with all-cause mortality. And those, let's see, 4 factors were elevated troponin, an elevated BNP, the presence of DVT on lower extremity ultrasound, and a simplified PESI score of greater than 0. And so, like we talked about, SPESI is a good score to use to identify patients who may be safe to treat in the outpatient setting. Using this multi-marker prognostication model can help identify normotensive patients who are at the highest risk of PE-related complications among the patients that you admit to the hospital. So they found that if patients who had all 4 markers, had an elevated troponin, had elevated BNP, had a DVT on lower extremity ultrasound, and had an elevated SPESI score, they had a 5-fold increase in the risk of an adverse outcome at 30 days. And of note, only of the various scoring models we've discussed, none of them take into account clot burden. So now we come to management. I'll briefly touch on massive PE, but the indication you give thrombolysis there. So I'll spend a lot more time on what to do about submassive PE and how we think about that, as well as anticoagulation options for patients with PE. I won't touch on catheter-directed interventions because there are a whole lot, and it could be a talk in itself, and I'm not sure how widely publicly available those therapies are. And so to touch on thrombolytic therapy for massive PE, so I believe this is the first patient, or this is the first trial of lytics. They call it a randomized control trial. It had 8 patients in it. All 8 patients presented with massive PE and cardiogenic shock, and they were randomized. So patients got streptokinase and heparin, and 4 patients got heparin alone. So in the lytic arm, the 4 patients who got streptokinase and heparin, they all survived, and they follow these patients forward, and at 2 years, none of them had pulmonary hypertension. In contrast, all 4 patients in the heparin monotherapy arm died. And so this has been replicated in other studies. So we do feel comfortable recommending administration of thrombolytics for patients with massive PE, which again is PE with hemodynamic instability. So then that brings us to lytics for submassive PE. And so, thinking through why we might want to give it, of course, we want to reduce people's risk of adverse events, both in the acute setting. We want to reduce the risk of hemodynamic collapse. We also want to reduce the risk of, let's say, long-term complications like the development of chronic thromboembolic pulmonary hypertension. So it's not crazy to think, like, should we give lytics for submassive PE? But this is where the literature can be really helpful. So there was a randomized controlled trial that was published, I believe, in 2016 of tenecteplase plus heparin versus placebo and heparin in normotensive patients who had evidence of RV dysfunction on imaging, as well as myocardial injury, which was defined as an elevated troponin. So again, these would be patients who would be classified as submassive PE, also known as intermediate high-risk PE. And this was a multi-center, placebo-controlled, double-blinded trial conducted at multiple hospitals in Paris. And so the primary outcome of this study was death or hemodynamic decompensation within 7 days. They also looked at safety outcomes, which were primarily bleeding related. So major extracranial bleeding or stroke within 7 days. And so to start with their primary outcome, so they found that, if you, in the group that received lytics, they had a lower rate of your primary outcome at 7 days. But if you look at the table, there's not a difference in mortality. So the difference in the primary outcome was driven primarily by less hemodynamic decompensation in the first 7 days in the group that received lytics. Then if we go on to looking at safety outcomes, so major extracranial bleeding was a lot more common in people who received lytics. So it occurred in 32 patients in the tenecteplase group versus 6 in the placebo group. And then if we look at stroke, we see that stroke occurred in 12 patients in the tenecteplase group. And of those 12 strokes, 10 were hemorrhagic, compared to 1 stroke in the placebo group, which was hemorrhagic. And so based on, so this study shows us that you may have less hemodynamic decompensation at 7 days, you don't see a difference in mortality, and you see a marked increase in extracranial and intracranial bleeding. And so based on that, the authors concluded, this is, I believe, the last sentence in the paper, great caution is warranted when considering fibrinolytic therapy for hemodynamically stable patients with pulmonary embolism, right ventricular dysfunction, and a positive cardiac troponin test. And so that RCT was kind of a game changer. And so you look and you see how guidelines that were published before and after that paper came out have changed. And so I, in this talk, have only included guidelines that were published after that paper came out, because it's, important to have up-to-date guidelines. And so these are guidelines from the American College of Chest Physicians, published in 2016. And their recommendation for systemic thrombolytic therapy for PE, if you have hemodynamic instability, they recommend administering thrombolytic therapy. If you do not have hypotension, they recommend against administering thrombolytic therapy unless you see patients have clinical deterioration after starting anticoagulation. And then in that case, they say, if you have hemodynamic instability, they recommend against administering thrombolytic therapy unless you see patients have clinical deterioration after starting anticoagulation. And then in that case, they say, if you have hemodynamic instability, they recommend against administering thrombolytic therapy unless you see patients have clinical deterioration after starting anticoagulation. reassessing the risk-benefit ratio may favor the administration of lytics in patients who have intermediate to high-risk PE and show evidence of clinical decompensation despite being on therapeutic anticoagulation. And by and large, this is consistent with guidelines that were published by the European Society of Cardiology and the European Respiratory Society in 2019. And they say that full dose systemic thrombolysis is not recommended as a primary therapy for patients with submassive PE. And their recommendation is in patients who have intermediate to high risk PE, you observe them for 2 to 3 days on low molecular weight heparin. And if hemodynamic compromise develops, then you would consider rescue thrombolytic therapy in that setting. And they have an algorithm that we can go over. So, which I think it has one sort of glaring omission, which we'll get to. But you have a patient presenting with PE, you start them on anticoagulation, and then you look at their hemodynamic stability. So if they're unstable, then they fall into this high risk category, and you would treat them with reperfusion using thrombolytics. If they do not have hemodynamic instability, then you look for signs of intermediate to high risk PE, which we've talked about. Do they have a high PESI score? Do they have RV dysfunction? And if they do have RV dysfunction, do they have evidence of cardiac injury? And so if they fall into the intermediate high risk category, then you would anticoagulate and monitor them, and you would consider lytics if they decompensated. The glaring omission here is that it has no mention of assessing for contraindications to lytics, which is very important. So as a reminder, we've got absolute and relative contraindications to thrombolytics. So absolute, of course, if you have a stroke, particularly a recent stroke, if you've got a intracranial mass, if you've had major trauma, surgery, or head injury in the last 3 weeks, and if you've got bleeding, active bleeding. Then you have more relative contraindications, TIA in the past 6 months, use of oral anticoagulation, pregnancy, non-compressible puncture sites, traumatic resuscitation, refractory hypertension, advanced liver disease, endocarditis, or an active ulcer. And so that's my sort of spiel on lytics. So moving on from that to anticoagulation regimens. So you have options. So in the initial phase, it used to be that everybody was bridged with low molecular weight heparin or heparin and then started on warfarin. But with the advent of direct oral anticoagulation agents, of which there's many on the market, we now can treat certain patients with only oral regimens. So if you're using apixaban or rivaroxaban, you load for the first week, then you drop the dose down for your long-term, like the first 3 months of therapy. If you are using warfarin, edoxaban, or dabigatran, then you do need to bridge with low molecular weight heparin. And so most, I'm not really touching on duration of anticoagulation. Most patients with a provoked PE, you'll treat them for 3 months. If they've got malignancy-associated PE, if you can't find a provoking factor, if it's recurrent, then you would treat them for longer and potentially indefinitely. So coming back to COVID-19 and PE. So we've already discussed the increased incidence of PE in patients with COVID-19 and the fact that it occurs despite the use of standard DVT prophylaxis regimens. So that raises the question of what is the optimal approach to VTE prevention in patients with COVID. Unfortunately, we don't have any RCTs that I'm aware of, unless I missed them, and I did not see any national or international guidelines. I did find a paper that was just published last month that was an observational study of enhanced thromboprophylaxis in 852 critically ill COVID-19 patients in 28 ICUs across Europe. And so this is observational, it's retrospective, and so there wasn't very much standardization. So what the definition of enhanced thromboprophylaxis differed from hospital to hospital. The most common regimen, though, was the use of enoxaparin at anywhere between 40 and 80 milligrams twice a day. So of the 852 patients, 32 received enhanced thromboprophylaxis. 51 received standard prophylaxis, and 17 already had an indication for therapeutic anticoagulation. And so their analysis is a little bit wonky. So using propensity matching, they found that enhanced thromboprophylaxis was associated with reduced mortality without an increased risk of bleeding, but they present their findings as log odds. So it's a little bit difficult to translate that into like risk for patients. But it's a promising finding. And so I can only comment on my institutional experience. So I can say that at Duke University, where I work in the US, we've come up with inpatient anticoagulation protocols for ICU patients and non-ICU patients. And it takes into account D-dimer, presence of VTE, and then their overall individualized thrombotic or bleeding risk. So this is for non-ICU patients. So you know, as part of your initial workup, you get a D-dimer. If it is not elevated, then you would put those patients into like a standard prophylactic dose category. If it is elevated and they have evidence of VTE, then you will treat them with a therapeutic dose. But if it's elevated and they don't have VTE, then you take a look at the individual bleeding and thrombotic risk, and you either give them prophylaxis or you can give them sort of an intermediate dose of enoxaparin at 0.5 milligrams per kilogram Q12. And I will say, if we use heparin infusions, let's say for patients who have renal failure or some other contraindication to low molecular weight heparin, we titrate to heparin levels or 10A levels. We do not use PTT for a heparin titration in patients with COVID. And the observational study that I mentioned earlier, they also asked about monitoring parameters and whether ICUs use PTT or 10A levels. And the vast majority, I think there was only one ICU out of the 28 that used 10A levels. So you'll see some variation from institution to institution. And then the anticoagulation protocol tends to be a little bit more aggressive if you're in the ICU. Obviously, you're critically ill. So if you have a normal D-dimer, then you will get either a prophylactic or intermediate dose. If you have an elevated D-dimer and you have VTE, then you get therapeutic dose. If you don't have VTE, or we don't know whether or not you have VTE, you'll either get intermediate dose or therapeutic dose. And that again it's sort of an individualized decision based on individual bleeding risk and thrombotic potential. And this is, as I mentioned, just one institution's experience. And so you will see some variability. So in summary, the take-home points: PE is increasingly common in the COVID-19 era. Risk stratification is important for prognostication and management. Thrombolytic therapy is indicated in massive PE, again, is defined as PE with hemodynamic instability. However, in submassive, also known as intermediate to high-risk PE, we should avoid thrombolytic therapy as our first line and reserve it only for those patients who have clinical decompensation despite therapeutic anticoagulation. And then lastly, enhanced thromboprophylaxis may be beneficial in COVID-19, but more studies are needed. So these are my references, and I thank you all very much for your attention.
Thank you so much, Sweta, for that insightful talk. I think personally for me, the management, especially the questions surrounding lytics and what we really do about these patients that are critically ill, both in the CPAP and the ICU, in our setting, given that we do have lytics available. I think it's time for the Q&A. I see Dr. Gaolathe is raising up her hand. Can somebody please unmute her?
Great. Thank you. So this is Dr. Gaolathe at Kitumile. Just to add on our clinical experience here at Kitumile. Thank you, Sweta, for a great presentation. puts it into perspective, at least from a theoretical point of view. So basically what, I was kneeling down, okay, sorry. So basically our experience here at Sekitumile, I'm glad she touched on the enhanced thromboembolic prophylaxis. For most of our patients, because we're an acute care center really, we give therapeutic dosing of Clexane, 80 BD, depending on weight. For our patients, all patients that come through Sekitumile. We also have an enhanced protocol where all patients really should come through, have a CT or CTPA, depending on what they present with. And in general, we have seen PEs and a lot of PEs. And on estimate, I've just been reaching out to our radiologist, he hasn't responded. I would guesstimate it at about 20% or so. But this is something, there's data that we'll be looking into, and a little bit higher for those patients on CPAP. So this really begs the question, because we do scan at baseline, we didn't see the PE, but also because CPAP is intense monitoring. When the parameters change, they become tachycardic, hemodynamic issues, we do have an opportunity to rescan. And there we pick, I would say, about 30% of PEs. In terms of therapeutics, we are fortunate, we do have access, we use Altepace. And of course, we do also risk stratify. We have a very active radiologist who picks them up on the spot as they are scanned. And what we've also looked at the hemodynamic aspect. We don't see that as much as more the right ventricular strain and also reflux into the IVC. So really we have, of course, we do risk stratify for those who may be hypertensive with cancer or other issues that may predispose them to bleeding. And we have basically had a good success rate with thrombolysis. And long-term, we do have access to dabigatran, though the supplies can be erratic, but of course with a backup of warfarin, but most of our patients we put on dabigatran. I think Dr. Palai can also elaborate on that since he handles quite a bit of the pulmonology aspect. And we have seen patients on discharge, scans were clean, they may represent with hemoptysis. We recently had one and newly found PE. I think sometimes that's where the dilemma is in terms of management. Of course, they're coming with hemoptysis. This is a young fella. There's a big clot there. Yes, hemodynamically stable. But we do err on the side of dabigatran. Thank you. I think Palai can add to that.
Yeah, thank you so much, Dr. G. I think you've covered most aspects of what we really do at Sekitumile. I think what I will say is, you know, we have lysed quite a number of patients in the CPAP unit, some in the isolation, I think about 4. We do 100 milligrams of Altepace over 2 hours. We do monitor for anaphylaxis and any side effects. I think Dr. Patel did allude to contraindications. So we do have to look at, you know, any change in mental status to suggest any intracerebral hemorrhage. So it's something that's, you know, we take seriously. We've had one complication recently of a patient getting, I think, epistaxis about 2 hours after lytic, after Altepace administration. But otherwise, I don't think we've reported any other adverse reactions from that. We are seeing patients in the wards with both central and peripheral, mostly peripheral. We worry about, you know, chronic thromboembolic pulmonary hypertension. Most of these patients are either on dabigatran or warfarin, like Dr. Gaolathe said. And I really, I pick the choice of anticoagulant given the access to an INR facility, clinic, physician, in the area. And unfortunately, most of these patients that have peripheral emboli, which are usually multiple, also have severe COVID. So you'll find that most of them are also on steroids to try to retard the fibrosis, as well as melt the opacities away. However, I think probably we have been discussing Dr. Patel. We will try to come up with our own protocol, make a few changes to it, specific to Sekitumile. And I think it's also going to be important to try to come up with a protocol probably that can be used in the peripheries as well, depending on the medications that are available. Just to go through the questions that were sent before the presentation today. Question 1 is from Chipomo Horosi. It says, Sweta, can a patient who has had defects in clotting factors be on warfarin for life?
So I assume that that is referring to patients who have thrombophilia from protein C or protein S deficiency.
Yeah, factor and so forth.
And so yes, I would say there's the thought that in patients with protein C deficiency, if you give them warfarin, they're at higher risk for warfarin-induced skin necrosis. And so for patients with protein C deficiency, if you have access to direct oral anticoagulants and the patient is a good candidate, I may lean towards using that instead. If warfarin is your only option, making sure that you bridge through that initial thrombophilic period and potentially starting at a lower warfarin dose and keeping them at the lower end of the INR range. But yes, you can.
Okay, thanks, Sweta. Question 2 from Shirley Kijile Pula. What is its association with COVID-19? I think she's asking association of COVID-19 and pulmonary embolus.
Yes, so there is a strong association. And I saw something about the pathophysiology. If I talked, I would be hand waving for what that is. Something about the virus's interaction with the body is prothrombotic. I know that's not helpful, but yeah.
Yes, I mean, I think just to add on to that as well. Towards the end of last year, University of Cape Town and Groote Hospital actually had a webinar where they spoke about the actual virus, its relationship to blood vessels, its prothrombotic nature, and they actually use pathology specimens. And it was during around the time when they were getting lots and lots of deaths during their second wave. So there is a strong relationship in that the virus itself, it's inherently very thrombotic. It forms different organs were shown, the liver, the kidneys, in patients who are in ICU that develop acute kidney injury that require dialysis, that, it's microthrombi throughout all these organs of COVID patients that eventually actually die in the ICU setting. I think it covers Mbenge's question briefly, why increased risk of PE with COVID-19. I think it's around the same concept, that because of the virus itself, it's prothrombotic. It forms small clots. It has propensity to form bigger clots. We've seen, if our radiologist is here, we've seen massive PEs. We've seen small or showering PEs in our patients. So I think the patient as well as the risk factors really matter here. And then the next question, Sweta, is there room for the use of anti-embolism stockings, so compression stockings as prophylaxis for all patients who are likely to have extended periods of immobility?
Yeah, I mean, I'm going back to our, so in a perfect world, for most of our patients, particularly in the ICU in the US, everyone has sequential compression devices for mechanical DVT prophylaxis, and that becomes crucial for people who have a contraindication to anticoagulation. So I would say, yes, it is very unlikely to cause harm, and you may see a benefit.
Yes, I do agree. I mean, compression stockings do help, I think, across patients who have all sorts of thromboembolic issues. It'd be interesting to look for a paper or literature supporting this, but I do believe there are ICUs somewhere around the world using compression stockings. And then Dr. Deimari says, do you suggest anticoagulation after discharge until 28 days from positive? I think it's 3 months. Three months, Sweta did say, and that's what most guidelines say. Don't know, Sweta.
Is this for patients with diagnosed PE or patients with COVID who do not have a known PE? Because if it's a diagnosed PE, then yes, it would be 3 months or longer, depending on their risk factors and whether or not it was provoked. If we're just discussing adult patients with COVID who don't have evidence of VTE, I'm not aware of any guidelines to support discharging these folks on anticoagulation.
Yes, this has been.
But it's an active area of investigation.
Yes, some centers have actually used aspirin. There's no evidence of it. Some people, I remember in the earlier first, second waves, some people were sent home on anticoagulation, no evidence of it. I think it's because most hospitals were overwhelmed, rather than it was more of being overwhelmed, not an evidence-based practice. So I think 28 days would really be clinical judgment. It's based on a physician making a decision, but really I've not come across any evidence of it. If it's just COVID and you're discharging a patient, I've not come across that. I don't know if there are any, just checking for any hands that may be raised for somebody who may want to ask questions. I think we can take a Q&A from the audience if somebody wants to speak and ask. Sweta, we do have it's 5 minutes before 5. So we do have some time. I don't see any hands raised. I think these were the really good questions that were asked. I think I encourage everybody in different centers, different parts of the country to continue to discuss such patients, especially patients that seem to decompensate and get worse, that were initially doing well on steroids and anticoagulation. So I think always have a high index of clinical suspicion for PE if there's no other reason like a hospital-acquired pneumonia, sepsis, or anything else. We are happy to discuss these patients, get them scanned, and get them managed. Apart from that, I think I will offer Dr. Gaolathe just to give us some closing remarks. Oh,
I'm a bit late. I was absent part of the meeting. Just wondering, maybe you said so, Sweta, but do you think all patients that die actually have pulmonary embolism and the coagulation system activated? Is this part of the cause of death, or is it just the severe inflammation?
I think it's a really interesting question. And I bet that if we did sort of an autopsy series on patients with COVID, we'd uncover a very high rate of PE. I wonder, given how prothrombotic it is, like if the majority of patients who die have some evidence of like microthrombosis, but I think a fair number are, well, I can't say it because we don't have autopsies. the lung injury and refractory hypoxemia and severity of the ARDS I've seen in these patients would be enough as a cause of death on its own. But that being said, I suspect if we looked, we'd find a very high rate of thrombotic complications in the patients that die.
Thank you.
All right. Thanks, Sweta. I see our radiologist was actually unmuted. Maybe Dr. G wants to give them a chance to say a few things before her closing remarks.
Okay. Many thanks, Dr. Patel, for a very wonderful presentation. Just one or two things probably from my end. We have a reasonably very good CT scanner, and I'd be very curious with the findings that Dr. Palai mentioned from Cape Town, because generally, very informally, you follow pulmonary veins to the atrium and you actually find out there are small filling defects. Very, very interesting, because it would suggest, like you were mentioning, the thromboembolic phenomenon. We are only looking at the pulmonary arteries and its branches, but there probably are clots also sitting in the venous system as part of the thromboembolic phenomenon. So that's one thing I'd probably ask Dr. Palai, if you have more on that, I'd be very willing to correlate what we find from our end. And then secondly, we were looking at the numbers generally for us, like Dr. G said, roughly probably a third. There was a period, February, March, when we were picking up quite a lot of PEs actually. At that point, it was probably up to a third that were positive on the scans that we have. But lately, it looks like we're being very liberal with our CTPAs. Our pickup rate really has gone down. So probably just reflects that maybe now we are overdoing it. There might be a few pointers that help us pick out who should get a CTPA and who shouldn't. Much more, how would I put it? In a more, well, we are privileged to have the CT to be able to do it. But in another resource-limited setting, one might need to be a bit more prudent in terms of picking out who gets to have a CTPA. All right.
Yeah, I think that's a really great point.
Thanks, Tashi. I will find that webinar and the papers that they shared, because I think it would really allude and clear a lot of the confusion and always keep us on our toes in terms of suspecting pulmonary embolus and managing it appropriately. I think I'll give Dr. G the floor now.
Thank you, Tommy. And just to thank all of you who were able to participate today. I think because we had taken a break on our webinars, we need to spread the word again that we are back every Thursday. We are working on our lineup, and I think will have interesting topics coming up, including vaccine, which is still a thorny issue here in Botswana in terms of access, and even from the program that has started, what has been the experience. I think also what we may have lined up has always been a topic of interest that speaks to the variants that we hope will have something. They would have come hopefully, but it's still work in progress. But that is also something, some topic that is coming up. We also invite you to suggest what areas you would really like us to cover. We haven't received much, but we would invite you and even you to come as presenters to share your experience in the different settings that you work in. So I think with that, let me thank Dr. Sweta Patel, who has been with us here also from a mentoring perspective at SEKI as a critical care specialist for her 2 presentations. So we hope we will have her on and off. Thank you. Have a good day all.
Thank you.